Hello everyone, welcome to Study with me on channel Dr. Tanya Dua. Okay, today we are going to talk about portal hypertension. What is portal hypertension? It is elevation of portal venous pressure above 10 to 12 mmHg, which is normal जो है वो 5 to 10 mmHg होता है normal portal venous pressure, and it is elevation in that normal pressure. So 10 to 12 mmHg, if it is above the normal, that is 5 to 10 mmHg, it is considered as portal hypertension. Portal hypertension results from, now there could be two reasons for this. So we'll talk about them. First is increased resistance to portal blood flow. Okay, could be high portal blood flow. The blood is like gushing. Okay, so there is high portal blood flow, or there is increased resistance to portal blood flow. Okay, most commonly it is due to increased resistance. Then there what kind of obstructions are there? According to that, we have classified it into three. Portal hypertension could be pre-sinusoidal, sinusoidal, and post-sinusoidal. Okay, so they have mentioned pre-sinusoidal, sinusoidal, and post-sinusoidal. Okay, so there is portal vein obstruction. Now, portal vein, okay, it can be obstructed by thrombus. Okay, it could be trauma, malignancy, and malignant disease of pancreas. Okay, then intrahepatic, it could be due to schistosomiasis and sarcoidosis, vinyl chloride. Okay, sarcoidosis and schistosomiasis. And then sinusoidal, it could be due to cirrhosis or metastatic liver disease. And post sinusoidal, it could be veno-occlusive disease, and extrahepatic due to Budd-Chiari syndrome, that is hepatic vein thrombosis. Common cause is liver cirrhosis. Okay, portal vein obstruction is the second cause. Okay, most that is due to that portal hypertension will occur most commonly is due to cirrhosis. Then clinical features. The clinical features result from portal systemic collateral formation and portal venous congestion. Okay, as there are no valves in the portal vein. Portal vein doesn't have any valves. Okay, so retrograde blood flow from portal venous system, high pressure, to systemic venous circulation, low pressure, occurs during portal hypertension. Now, main clinical features are hemorrhage from rupture of varices, hematemesis. What happens? There is blood in form of vomit. Okay, so what happened? Because of this so much of pressure, these blood vessels rupture. Okay, and there is um, blood in the form of vomitus. Okay, hematemesis. Then ascites. Okay, you know what is ascites? It is fluid accumulation in the peritoneum. Okay, then splenomegaly. Okay, hypersplenism, and hepatic encephalopathy is also there. Okay, so one has to remember these things. Then splenomegaly is the cardinal finding of portal hypertension. Okay, what happens if you are finding splenomegaly? You will palpate the spleen and you will see there, you can feel a bulge or something. So splenomegaly is there. And if you find that there is splenomegaly, that is spleen megalo matlab it has become big, so it has increased in size. So that is the cardinal sign. You can assure it is in portal hypertension, it is present. Then hypersplenism may give rise to thrombocytopenia. Okay, what happens if spleen is overactive. Okay, so what happens ki, spleen is the graveyard of cell. So all your uh, platelets and WBC both will get engulfed by the, both will be destroyed in these both will be destroyed in the spleen. Collateral formation occurs around the esophagus and stomach. Okay, so that is why esophageal varices and gastric varices, there will be formation of collaterals, because blood so much of collaterals will be formed. The rectum, hemorrhoids you can see. Okay, retroperitoneal space and periumbilically in anterior abdominal wall. Lateral vessels in the anterior abdominal wall may be visible as tortuous vessels radiating from the umbilicus. Caput medusae. What will you see? There will be tortuous vessels radiating from the umbilicus. Okay, so it like medusa, it has that hair, like hydra like hair. Okay, so many radiating from that. So caput medusae is very commonly seen in this thing when there are collateral vessels formed in the anterior abdominal wall. Okay, then as a result of portal systemic shunting, various toxic substances enter into systemic circulation without going to the liver. This is the basis for hepatic encephalopathy, musty odor of breath, fetor hepaticus due to the presence of mercaptans can occur in hepatic encephalopathy. Then what are the investigations? Endoscopy, very important. So endoscopy will help you to find out esophageal varices. Suggest, okay, ultrasonography. It is useful in the evaluation of size and texture of liver size, splenomegaly, diameter and flow of the pattern of portal vein, ascites and collateral circulation, all could be seen through ultrasonography. CT and MRI, they are not needed. Okay, because they are not needed. Now portal venous pressure, measurement of portal venous pressure is needed to confirm portal hypertension. In the starting only we told that when the portal helps in knowing the site and cause of the obstruction, so portal venography can be done. Now um, management includes reduction of pressure in the portal vein and treatment of the complications. How can you reduce the portal venous pressure? So you know that if you want to reduce pressure, you need beta blockers. Okay, so propranolol and nadolol can be used to lower the portal venous pressure. Transjugular intrahepatic portosystemic shunt and surgical decompression procedures are other options to decrease portal venous pressure. And treatment of complications like upper GI bleed, okay, ascites, spontaneous bacterial peritonitis, hepatic encephalopathy and hypersplenism are managed as given below. So okay, you can see in this diagram, we can see this is portal hypertension ka diagram. You can see caput medusae, you can see ascites, we can see umbilical hernia, we can see gynecomastia, we can see edema. Okay, all these are one of the portal A B C D E, that is ascites, bleeding, piles, everything. Okay, bleeding can be piles. C caput medusae. D diminished liver and enlarged spleen. Okay,